I would like to convince you that this small gadget we are keeping in pockets, the mobile phone, is capable to substantially reduce the number of relapses and rehospitalizations in schizophrenia. And I would like also to share with you the experience with the telemedicine program which has been introduced in Czech Republic 8 years ago, and which shows very clearly that we really can eliminate relapses in schizophrenia to some extent, but there's a lot of pitfalls on the way, and I will deal with them in my speech. So first of all, there's an urgent need to introduce the effective relapse prevention programs in schizophrenia because of the enormously high rate of relapses which we have in this illness, which is shown here, for example, in this meta-analysis by Stephen Lloyd, that show us that despite the fact that you have your patient on medication, there's an annual relapse rate in schizophrenia, nearly 30% relapse rate in schizophrenia, so that this is really very high, and there's the effect of revolving door with all collateral effects. So that was the incentive for development of telemedicine e-health program, which has been developed in my facility in Prague Psychiatric Center and introduced into the clinical practice not only in Czech Republic but also in Slovak Republic and recently also in Japan. The program is based on very simple logic. Before the onset of full-blown relapse, we have the certain period of early warning signs or prodromes, if you want, which has certain phenomenology, and the crucial fact is how to detect them and how to deliver this information to the treating doctor so that he or she can take some appropriate pharmacological measure. So that with ITREPS we have involved both patient and optionally also family member. All of them are sending the SMS upon the SMS prompt, which is automatically generated by the system and sent to their mobile phones. And the participants are instructed to detect the proportional worsenings in their early warning symptoms compared to the baseline, which is last week's completion of the questionnaire. They are sending 10 item early warning signs questionnaires. And the additive value of this system is specific mathematical algorithm which has been developed in cooperation with the cybernetics from Czech Technical University in Prague, which was based on data mining techniques, which was analyzed over the data which are right now in database. And this mathematical algorithm is capable to recognize the early warning signs and to send a specific alert by email to the doctor, so the doctor is instructed to increase the dose of medication within 24 hours after the receiving of alert. So we have two versions of 10 item early warning signs questionnaires, first one for patients, the second for family members. We are covering all non-specific but also specific early warning signs which precedes the individual relapse. The patients and family members are sending the string of 10 digits so that every single item is scored according to the 5-point scale. If there is no change compared to the last week's completion, they write down 0, and if there are some worsening from minimal to extreme, they write down from 1 to 4, so that the result is the string of 10 digits which is sent as the SMS back to the system. And we have carried out several studies. 2 of them were mirror design before-after studies, and we have also 2 absolutely independent randomized studies. Randomized control studies, first one conducted in Czech Republic and the second one in 4 university sites across Japan. So this is for illustration, this is the result of the latest before and after study, a mirror image study showing us the number of hospitalization days before the enrollment to the ITREPS and after the enrollment in 134 patients, you can see that this is a clear-cut decrease and reduction in the number of hospitalization days by 60–70%. And what we did also a robustness analysis, so that right now we can conclude that all the effect is attributable not only to ITERAPS itself. And this is the result of a Japanese randomized controlled study, which shows us that we are capable with ITERAPS compared to the control group, reduce the risk of hospitalization down to 1/5, and the effect size is quite nice. As you can see, the number needed to treat is 4. And what they have shown, this is really illustrative, they have active group in which patients were enrolled in the ITERAPS compared to the treatment as usual group. And despite the fact that both groups were comparable in terms of the number of patients enrolled in all the groups, you can see the strong difference between both groups in terms of the number of hospitalization days, so that they had in the control group 710 hospitalization days compared to 37. So that this is decreased by 90% in the number of hospitalization days. And back to the question, to the main question, can we predict the relapse? And right now I would like to share with you the data which we have from the double-blind randomized study which was conducted in Czech Republic. And this is the quite typical example from the control study. So that this is the natural cause of schizophrenia during the 1-year follow-up. In the control group, in both active and control group, participants were instructed to send the SMS, but in control group, the feedback from the system to the doctor has been withdrawn. So this is the natural cause, and as you can see here, this cross shows us the relapse without hospitalization. Those bold horizontal lines shows the hospitalizations, 2 hospitalizations here, the scores of SMS, and the vertical blue line shows us the alert which was not sent to the doctor but was elicited by the system. And you can see that that's quite fair predictive value of the system, as you can see, so that it predicted both relapse and hospitalizations right before the full-blown onset, in average 1 month before the hospitalization or the occurrence of relapse. But the first and main problem which we have detected using ITERAPS is that the prodromes are really very subtle. In the active group, we were asking doctors how did they perceive from clinical point of view the clinical status of the patient when the alert was announced, and the answer is that they didn't see any change. So that, as you can see, the median CGI, clinical global impression, when the alert was elicited at the very early stage of prodromes was 4, so that there was no clinical worsening, no clinical decline as was seen or detected by the doctors. So it resulted in the fact that our double-blind randomized study was completely failed study because of total non-adherence of investigators, not patients, but investigators, because investigators did not respond by increasing the dose of medication in 60% of all alerts announced by the system, because they didn't see any change, didn't see any worsening, despite the fact that they were aware that this is the violence of the protocol. So that we are completely reluctant to increase the dose of medication if we don't see really substantial decline in the clinical status of the patient. So this is the first obstacle. The second one is that, generally speaking, all early warning signs questionnaires which are used in the field have a low predictive accuracy. So this is the table which is summarizing all studies which were using different kinds of early warning signs questionnaires. And as you can see, the result is that the median sensitivity is something around 60% and specificity is something about 80%. So this is quite low. But and this is well illustrated here. This is the example of our patient, one of many, from the active group. You can see here, this is the hospitalization, but before that, there was no report of any worsening reported by the patient or family member. So probably what's behind that is that the brain is a complex, non-linear dynamic system, and system of that kind behave in a specific way. This is the model of such a mathematical model of such a system, which bifurcates here into, say, stage A or state B, and we can see it as the relapse or non-relapse. And it goes, firstly, it goes through the episode of gross instability, and then it bifurcates. But it bifurcates completely spontaneously to the either state A or state B. So that the practical conclusion is that if you have prodromes in your patient, it can resolve completely spontaneously, without any pharmacological intervention. So you may imagine how much it hampers sensitivity of all tools we have. The third pitfall is the disputable dosage strategy which we use in our clinical practice. I would like to illustrate it in two pictures or two time frames from two patients. Here in this violent line we depict the dosage of antipsychotic medication here in milligrams of chlorpromazine equivalent. As you can see, this is absolutely typical. After the enrollment to the ITEREPs, there is some reduction in the dose. The alert which is announced to the doctor, which is completely ignored, there's no intervention. Then we have hospitalization, and after hospitalization there's substantial increase in the dose of medication. But more obviously we have the second example, in which you can see in the dashed lines, those are all alerts or announcements from the system that the patient is facing early warning signs symptoms. As you can see, there's no intervention nearly during the 7 months period. After that, there's the short hospitalization, after which the patient has been switched to the another medication, but you can see that it's even lower in terms of the milligrams of chlorpromazine equivalent. So that this is proof that 15 milligrams of olanzapine is not equal to 400 milligrams of quetiapine. So what we did, we just looked at the SMS as a proxy of clinical stability. We had 30,000 SMS from nearly 200 patients, in total 250 patient years, and the question was quite simple: is there any correlation between the dose and the stability? So that we have looked at the 1 month time frames at those two variables. And what we did, we divided the dosage into three dose ranges according to the equal-binning methodology. That means that in every range we had the same number of observations. And what we have seen, that there's something like therapeutic window between 200 and 400 milligrams of chlorpromazine equivalent, in which we have the most stable patients. What's below that, probably those are underdosed, so that they are prone to more instability. But what's very interesting is that we had more instability also in those who were on higher doses. And of course, there's a question what comes the first, the hen or egg, so that they were probably on higher doses because they were unstable. But we did a causal analysis which showed us that that it was completely reversal, that the causality was completely reversal, so that those people were kept on higher doses and therefore they were unstable. It corresponds to the older studies with the plasmatic concentration of haloperidol compared to the clinical improvement. That again shows us that there is a specific window, therapeutic window. What's below leads to less improvement. But even if you have high concentration of haloperidol, then you can have more complications and more instability and less improvement. And the conclusion of those authors of this meta-analysis is that here you have more side effects which somehow amalgamize with the scales which were used in those studies. So, in conclusion, the answer is yes, we can reduce the relapse rates, but we have three problems at least. And now I'm not speaking about non-adherence of patients and the other stuff, but we have at least three problems. The first one is that really programs are subtle and that we are not going to defer our authority to some machine-like system which tells us increase the dose of medication despite the fact that you don't see any worsening. So that the problem is that we probably should somehow change our clinical thinking to achieve the goal of establishing or implementation of efficient relapse prevention program. The second is that we have low predictive accuracy, but you know this is intrinsic to nature of programs, and you know there's nothing to do about that. This is like it is. But the third is that we should improve our clinical behavior, and ITREPs provide insight into the outpatient practice. The good message is that right now we have efficient relapse prevention program, ITREPs, which can be, and this is the charm of all those electronic things, we can introduce it across the globe within 2 or 3 months, so that if you are interested, don't hesitate and contact me. Thank you for your kind attention.